Hello, everyone, and thank you for joining us today. Today, I have the pleasure and the honor of introducing Dr. Charlene Fell, Clinical Associate Professor of Medicine, the Director of the University of Calgary Interstitial Lung Disease Program, the founding chair of the Canadian Thoracic Society Clinical Assembly on Interstitial Lung Diseases, and the current chair of the Canadian Pulmonary Fibrosis Foundation Medical Advisory Board. Thank you for joining us today, Dr. Fell. And again, it's an honor and pleasure to hear this topic that has been so greatly appreciated and wanted, because all these patients of ours always say, why do we do these tests? What do they mean? So thank you for joining us. And Dr. Fell, please.
Excellent. Thank you, Sharon, for the kind introduction. Hello, everyone. I cannot see you from my screen. But it's a pleasure to be with you this afternoon. I'm going to just get my slides up here for you to see. And I'm so pleased that Sharon asked me to present on this topic for you today. Can I just check in with Shane and Sharon that my slides have come up properly?
It's perfect.
Perfect, thank you. Yeah, because Sharon gets a lot of these questions. What are all these tests? Why am I doing them? I get a lot of these questions. I'm sure all of you are wondering why you have to do things over and over again. And so for the next 30, 40, 45 minutes or so, I'm going to go through the most important tests and why we do them, and spend a little bit of detail on what we think is most important for the diagnosis and management of people who have pulmonary fibrosis. So I'm located in Calgary, as Sharon said, and at this point, I'd like to acknowledge and pay tribute to the traditional territories of the people of Treaty 7, which is where we live here in Calgary at the confluence of the Bow and Elbow rivers. These lands have been inhabited for time immemorial by the peoples of the Blackfoot Confederacy, which are comprised of the Siksika, Piikani, and Kainai First Nations, Tsuut'ina First Nation, and the Stoney Nakoda Nation, which includes Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary and surrounding areas are also home to the Métis Nation of Alberta, Districts 5 and 6. These are my disclosures for the talk. I don't think any of them are really related here. What I didn't put on this slide for my disclosures is I sit on the Clinical Advisory Committee for the Respiratory Benefits Program for Alberta Health, which is the program that funds supplementary oxygen in the province of Alberta. I don't think it's a disclosure for this talk specifically, but it does relate to some of what I'm going to talk about later on. So as Sharon was saying, what are all these tests and why do I have to do them? So there's a few key questions that the respirologists, ILD specialists, or even your family doctor are trying to answer when we're ordering different tests as they relate to your lung or to your general health. And so the most important question at the very beginning of your journey, of course, is what kind of pulmonary fibrosis do you have, or what is the diagnosis? The other key things are, how are the lungs functioning? And then most importantly, how well is the person functioning with pulmonary fibrosis? And those two things go hand in hand. We want to know if or how the lung function is changing over time, since the majority of the diseases, the different kinds of pulmonary fibrosis do progress or get worse over time. So we want to be able to track that in some well. And then for patients who are on different kinds of medications for their pulmonary fibrosis, some of our testing is designed to help monitor for toxicity or side effects related to the therapy. So we're going to go through all of those topics in turn. The one thing I do want to point out, though, is that when we are making the diagnosis of pulmonary fibrosis, of all the different tests that we can do, and you can see them here, the history, physical exam, CT scan of the chest, HRCT, biopsy, pulmonary function, blood work. Of all of these things that we can do, the most important in terms of making the diagnosis are the history, and that is what you tell us about how you feel, where you live, where you grew up, what kind of work you did, your exposures. That's the history. That's probably the most important thing. Right next to that is the high resolution CT scan of the chest, and I'll go into that into some detail in a few minutes. And then the blood work. If we need to do a biopsy, then the biopsy is critical to make the diagnosis. We usually do a biopsy if the history, CT scan, and blood work are not allowing us to come to a diagnosis. And in those cases, a biopsy is needed and is critically important. The physical examination is helpful, but usually not diagnostic, because different kinds of pulmonary fibrosis can result in the same crackling sound in the lungs or clubbing of the fingers, as in the photograph there. And the lung function studies, or the PFTs, also are helpful, but not in determining the diagnosis, because they tell us how the lungs are functioning, but they don't tell us what has caused the problem. When we are looking at how a patient is doing with pulmonary fibrosis, then the relative importance of all of these tests is a little bit different. So the history, again, is important. So whether or not you're having trouble getting up that flight of stairs, or if it's just as easy as it was a year ago, the pulmonary function tests, we compare them over time to see how they're changing. We do a test called the 6-minute walk test, which also helps us understand how you are functioning or managing with pulmonary fibrosis. Blood work helps us monitor how you are managing with some of your medications. And the physical exam may sometimes help us clue into early signs that maybe the pulmonary fibrosis is changing, or maybe the heart or other organs might be becoming affected with the consequences of advancing pulmonary fibrosis. So there are all different kinds of tests that we can do when we're either seeing a patient in the ILD clinic for the first time, or as we are seeing you periodically throughout the year and years to monitor your progress with pulmonary fibrosis. So there's the pulmonary function test, the 6-minute walk test, other exercise test, imaging of the chest, blood work, echocardiogram, which is an ultrasound of the heart, and then invasive tests like bronchoscopy and surgical lung biopsy. And for the purpose of every visit that we do with patients, when we're thinking about ordering the test, your doctor is thinking about what information does each test provide, and then how is that information going to change either the diagnosis or what we do to manage the pulmonary fibrosis. So for example, is it going to allow me to offer a different treatment option like medication or physiotherapy? Is it going to make me think that this patient might benefit from oxygen? Are we going to think more about symptom management? Is there something new on the x-ray and maybe I need to look for pneumonia or cancer or something like that? And so every time we're thinking about ordering a test, we don't just order them willy-nilly. We think very carefully about what is the test telling us and how are we going to use it at our next visit for you. For the purpose of this talk, we're not going to go through every single one of the tests on this list. We're going to focus on the ones that provide the most valuable information for us on a day-to-day basis when we see patients in clinic. And those are the pulmonary function tests, specifically spirometry, or the forced vital capacity, 6-minute walk test, CT scan of the chest, and the blood work. If you have questions about the other things, and I think we can deal with the other tests at the end of the talk when we have some time. This is what we're going to focus on for the next 35, 45 minutes or so. All right, so let's get to it. We're going to talk about pulmonary function tests first, namely spirometry, diffusion capacity, and then exercise tests. These are the bread and butter tests that you will get sometimes before you see your respirologist. Often, every time you see a respirologist, they're hard to do. For those of you in the audience who are patients, you know they're hard to do. For those of you who are family members or caregivers or friends of patients and you haven't had a pulmonary function test done, they're really hard. A lot of people get nervous about doing them, and so I wanted to spend some time going through the how and why specifically. So spirometry and diffusion capacity are two different tests that we do in the pulmonary function lab. And this cartoon here shows a typical setup of a pulmonary function lab. The equipment here looks very similar to the equipment that we have at our ILD clinic at South Health Campus throughout Calgary. There are many different brands of pulmonary function test equipment, and so they might not look exactly like this. You, as a patient, you may or may not sit in this little booth here, but you do have a clip that you wear on your nose, and then you put your mouth in a mouthpiece, and then there's a machine here called the spirometer, which does all the measurements of pressure and flow. And then there is a computer here that integrates all of the data and provides us with the numbers that we need. The first part of pulmonary function testing is called spirometry. And so for those of you that have had this test before, this is the one where you do the really big breath in, and then you do a hard and fast blowout. And we can measure a number of different things with this particular maneuver, the big breath in and then the hard and fast blowout. But the key measurement for the purpose of pulmonary fibrosis is something called forced vital capacity, or FVC for short. FVC is an approximate measure of the size of the lungs. It's not exactly the size of the lungs, but it's a pretty good measurement of the size of the lungs. There is a lot of data regarding pulmonary fibrosis that is built on the forced vital capacity, and I'll show you that in a couple of minutes. Forced vital capacity is a number that is unique to every individual person, and so the thing that determines how big your lungs are is your gender, how tall you are, and how old you are, because as we get older, our lungs shrink a little bit. And then whether or not you have a lung condition or a lung disease also determines what the forced vital capacity is. So there's the forced vital capacity, and then we calculate a number called the forced vital capacity percent predicted, which I'll show you in just a minute. And that just compares you to a population of normal individuals of your age and gender and approximate height to compare you to what quote unquote normal lungs would be. In the ILD clinic, I'm less concerned about how an individual person compares to a greater population. I'm more concerned about how are you at the beginning, and then how do you compare 6 months later, and then 6 months after that. So I like to compare the person to their own values. Forced vital capacity gives us information about the lung size, of course. That helps us understand a little bit about the lung function. It helps to predict things like disease progression, mortality, and then really important in Canada, the forced vital capacity measurement is required for funding of the antifibrotic drugs, pirfenidone and nintedanib. One of the other tests that we do in the PFT lab is called diffusion capacity for carbon monoxide, or DLCO, or some doctors may just say it's the diffusion capacity. So this is a different test. So you can see on the cart here where the respiratory therapist is, there is a canister of gas. And for this diffusion capacity test, we have you breathe in air with a tiny, tiny amount of carbon monoxide in it. Tiny amount, not dangerous, very tiny. So you breathe that in for a few breaths, And then you fill your lungs with this gas mixture. You hold your breath for 10 seconds, and then you blow out all your air. And the spirometer and the computer will look at how much carbon monoxide was in the gas in your lungs when you took your breath in. And then the carbon monoxide will diffuse into your body, and then it will measure how much carbon monoxide is left when you breathe out. So it will be less carbon monoxide, and then we calculate a diffusion capacity for the lung for carbon monoxide. And we use carbon monoxide because it passes very readily through the lung to the blood. And it just is a gas that is very efficient for measuring diffusion across the lung to the blood because of its properties of diffusing very well. We don't do diffusion capacity with every lab test, and it does have very good data behind it to show that it is linked to disease severity and prognosis, but not quite as robust as the forced vital capacity. So how often are these tests done? It depends, and that's going to be my standard answer for this question as we move through the talk. For sure, you're going to get spirometry and diffusion capacity done at the time of diagnosis or perhaps earlier when you go see your family doctor complaining of cough or shortness of breath. Patients who are stable, who are being followed in the ILD clinics, will typically get the spirometry with the forced vital capacity and often the diffusion capacity every 6 to 12 months or so. If things are changing, we may do it every 3 months. Or if things are really changing, like say you're in the hospital with pneumonia, we may do a lung function study, and if it looks like it's really dropped, we may do another one in maybe 6 weeks to see if you've regained some lung function. So really how you are doing or what's happening in your life will determine how often we need to do the pulmonary function tests. For the purpose of drug funding, we need to do the forced vital capacity every 6 to 12 months, and every province has a schedule of periods of time of how often we need to do that forced vital capacity test. Some of the challenges with this test, and if you've done it, you will know it is a hard test. It is entirely reliant upon how much effort you put into the test. And the other trouble we have with especially forced vital capacity is cough. So it's a test that will trigger a cough because you take a big breath, you stretch out those lungs that are stiff with pulmonary fibrosis, and that triggers a cough in many people. You will notice when you do the pulmonary function test that you have to repeat that big breath in and out 3 times minimum, sometimes 5 times, sometimes 6 times, because the values have to be reproducible or within a certain amount from each other to make sure that the result is valid. But don't worry, because the respiratory therapist is going to take the very best one and report your very best number to the doctor. Spirometry and diffusion capacity are not available everywhere. And so if you live in a small center, you may need to come into a larger center to get those tests done. And then the other thing I just wanted to mention is for those people who have trouble with the test, either they're coughing, maybe they get dizzy with the test, we can do a different maneuver called a slow vital capacity, which is exactly like it sounds. You take a big breath, but instead of blowing it out hard and fast, which can make you cough, our respiratory therapist will have you blow it out slower and longer, pardon me, and that sometimes makes it easier to complete the test. Some provinces will take a slow vital capacity for drug funding, some provinces will not, and so your doctor will be able to determine if a slow vital capacity is a good test for you to try if you're having trouble with coughing during the test. So this is a cartoon of what the forced vital capacity looks like when it is presented to the doctor. So we have on the left-hand side here a graph of the forced vital capacity of a person with normal lungs. And Shane or Sharon, can you just check in to let me know, can you see my arrow moving?
Yes, I can see your arrow moving.
Excellent. And so the way that the graph works here is that where my arrow is the beginning of the big breath in. So, whoops, you take a big breath in and the curve draws like this down to the bottom and up. And then when you do your big breath out, the curve at the top goes up like this. So the bottom here is your breath in and the top is the breath out. And we have a nice big round curve. It kind of looks like a big chunky mountain or a nice ski slope, maybe nice and straight. And for this person, this forced vital capacity might be, you know, just under 4 liters, 3.87 liters, or maybe 97% predicted for this individual. For somebody with pulmonary fibrosis, you can see on the right that the shape of this flow volume curve is quite different. It's a lot skinnier, and that's because the lungs get smaller. And then the pointy part of the mountain is a lot pointier and steeper, and that's because the air goes out a little bit faster in pulmonary fibrosis because of the way the lung is affected by scarring. And so for this example, this forced vital capacity might be something lower, like 2.32 liters or 63% predicted, which we would say is kind of moderate reduction in the forced vital capacity. So that's kind of what the numbers look like when we get them from the respiratory therapist. And there's a big printout with columns of numbers, but these are the important ones when we're looking at pulmonary fibrosis. The reason why forced vital capacity is so important is because it really helps us understand how interstitial lung disease or pulmonary fibrosis behaves in both the individual patient and populations of patients or groups of patients. And so this is work that was done by Dr. Martin Kolb, who is at the Firestone Institute in Hamilton, Ontario. Some of you may know him, pardon me. And this shows that we can track the forced vital capacity. Here it's percent predicted, and we can see that there's groups of people who have a longer survival or a very slow change in their forced vital capacity. There's groups of people who have kind of, you know, a middle of the road survival. This might be like idiopathic pulmonary fibrosis without treatment, for example. Their forced vital capacity changes in a different rate of time. And then people with very severe disease would have a more rapid decline in their forced vital capacity. So that's one way that the forced vital capacity helps us understand disease behavior in big populations. And you can see just by these graphs that in order to generate this kind of graph, Dr. Kolb and his team were measuring forced vital capacity over, 6, 8, 10, 12 years in some patients. And so we do these measurements every 6 months, year over year in our big group of patients, much like the CarePF, the Canadian Registry for Pulmonary Fibrosis study run by Dr. Ryerson at UBC, and we can generate data like this that helps us understand what is the behavior of different kinds of pulmonary fibrosis among our patients in Canada. The other thing that's really important for forced vital capacity is that it is the key measurement that is used to determine if drugs are effective in treating different kinds of pulmonary fibrosis. So my slide here for the ASCEND study, pirfenidone on the left, it looks like that it did not import very well. So I'm going to have you look over to the right-hand side to the IMPULSIS study. And if you just look at this graph up here in the top right-hand corner, B, where I'm moving my mouse around here, this is a graph showing that people with idiopathic pulmonary fibrosis who were taking nintedanib, brand name Ofev, had a change in their forced vital capacity with this kind of blue-green line here. And people in the trial who were on the placebo or the sugar pill had a faster rate of decline of their forced vital capacity. And there's many trials for pirfenidone, nintedanib, IPF, other kinds of fibrotic interstitial lung disease. All of them use the forced vital capacity as the anchor measurement to the clinical trials. So the forced vital capacity is so very important for us understanding disease in populations, clinical trials to see if drugs are working, and then for me to determine with the patient sitting in front of me, what is their lung function doing now compared to where it was before. Really important test, and that's why we have you do it all the time. So a question I get all the time in the clinic is, what if my numbers are changing or going down? And most folks who come into the clinic for their PFTs, I would say everyone is a little bit anxious about what is their number going to show today and what does it mean? So I just put up some mock numbers here that could be a representative patient. And this patient in January of 2024 had a forced vital capacity of 3.25 liters or 78% predicted. And then when they came back in June for their 6-month follow-up, it wasn't really changed at all, 3.23 liters. But then when they came back for their next 6-month visit in December, their numbers went down. So it went from 3.23 liters to 3.07 liters, or from 78% to 72%. There's a couple questions here. So the first question is, what is an important change? So the literature says that a 10% change, either this percent predicted changing by 10% or this number changing by 10%, is clinically significant. And then there's other data that suggests that maybe a 4% or 6% change is important. And in our clinic and most of the big clinics around the country, we like to really catch changes when they're smaller, like 4% or 6%. The trouble is that your ability to do that hard, fast blow in and out will be different by 4 to 6% every time you do the test. You just can imagine, you can't do the blow exactly the same every single time. And so typically what we try to do if we see something like this is we try to think, oh, why could it be down? And so we talk to our patient, we take that history that I was telling you about earlier, and we try to figure out, is there something that's different? Do you have a cold or an infection? Maybe do you have any trouble with your heart or a new problem? Have you broken a rib? Do you have pain? Are you bloated and maybe your belly is pushing on your chest and so you can't do the test as well? Maybe you're just having a bad day in the lab. And so sometimes if people are having trouble finding parking in the parkade, or they're late because there was an accident on the highway on the way in, or they're a little bit rushed, or they had something happen in their family, or their head's just not in it that day. Sometimes people just have a bad day in the lab. And we have to think about that because this is an effort-dependent test. Or it could be that the pulmonary fibrosis might be worsening. And we want to determine if the pulmonary fibrosis is worsening when we see a change that is about 4 to 6%, and we don't want to wait until it's 10%. We want to catch it earlier, the sooner the better. So your doctor is going to have a look at this and have a conversation with you in the lab and try to figure out what's going on. Whether is this a real drop, or is it a bad day, or is there something else going on? And for this particular person, the doctor would have had the patient come back about 4 weeks later in January of 2025, where they repeat the breathing test, and it's gone back up to 3.2 or 77% predicted. So really not any different than it was before. And if you look back a year prior, it's not really any different from where it was in January of 2024. So pretty stable disease. And as it turns out, this patient had a bit of a cold that was brewing because her kid or grandkid came home sick from school, and they got a little bit sick, and then they got better. And then just to be sure, the doctor repeated the breathing test in March, and it had gone down a little bit, but not really that significantly at all, still 77%. So that's how we use the pulmonary function studies in the lab, and what we do when things are changing a little bit. Sharon, I'm just going to check in because I think my next slide is about exercise tests. So do we have any questions in the chat about the pulmonary function test before I move on?
No, not at the moment,
Okay.
Charlene. I have to say you're very good, because I, as an asthmatic person, have gone through exactly what you're saying. I had to go back because I had a bad day trying to get parking, and I just couldn't get the air out of my lungs.
Yeah, some people just have a bad day, and that happens, and we bring them back a few weeks later and retest them.
Yeah.
Everyone's allowed to have a bad day. All right, so on to exercise tests. So there are many, many different ways to assess and measure exercise when we think about lung health or cardiovascular health. I'm going to focus our discussion on the 6-minute walk test because it is the most common standardized test that we use in Canada to measure exercise and functional capacity in patients with pulmonary fibrosis, but it's not the other one, and I'll touch a little bit on the other ones in a minute. So the 6-minute walk test is a standardized walk test, and it requires a hallway that is 50 meters in length, and that's quite a long hallway. Like its name implies, you walk for 6 minutes, and the point is to walk as fast as you can without running to cover as much ground or as much distance as you can in the 6 minutes. And so we have a couple of hallways in our clinic where we run this test. We have 5-meter marks kind of taped onto the floor so we can measure the distance. We've got a cone at each end of the course, and you walk down the course, and then you have to pivot around the cone. And then our patients are hooked up to a heart rate and oxygen saturation monitor, so we can monitor heart rate and oxygen level when you are doing the walk. In the cartoon here, this patient has the oxygen saturation monitor probe on her finger, but we sometimes run into trouble with that because you swing your arm, and that can cause some problems with the sensor. And so in our lab and other labs across the country, sometimes we put the sensor on your forehead with a really fantastic white bandage headband to hold it in there. It's very stylish. We measure how far you walk, and then we ask you to rate on a scale of 1 to 10 how short of breath you are after doing the test. And all of those little bits of information are helpful for us to kind of assess your global exercise capacity. So this is a standardized way to measure fitness. It helps us determine if a patient might need oxygen. And in some provinces, it is required for oxygen funding, but not all provinces. And so where you live, maybe have different rules for oxygen funding. You may or may not have to do a formal 6-minute walk test. And then, of course, we use the test to assess change over time. For those patients who really have trouble doing a pulmonary function test because of coughing or feeling lightheaded or whatever, I will often use the 6-minute walk test if they can walk to see how things are changing over time.
Sorry, Charlene.
Yeah.
Someone wanted to ask, they didn't get a chance. They said that is there an absolute FVC level that could result in having your anti-fibrotic medicine being taken away?
Oh, yeah, that's a great question. So each province has a specific formula or set of guidelines for what forced vital capacity value they need in order to provide funding for the antifibrotic. And then they also have a value for when they think that the antifibrotic is not working. And so you have to have, in Alberta at least, and I think most provinces across the country, your forced vital capacity has to be 40% predicted or higher in order to get antifibrotic funded. In terms of the changes in forced vital capacity over time, so this is my personal opinion, I don't agree with this, but the powers that be, at least in Alberta and other provinces, have decided that if the forced vital capacity falls by 10% over the course of 6 months or sometimes 12 months, that the province or the funders will say that's a failure of therapy and they will stop the therapy. My personal opinion is I disagree with that because none of the studies have ever shown that the antifibrotics are going to stop the pulmonary fibrosis from getting worse. They do get worse, just at a slower pace. And we also know that if patients are on an antifibrotic and their lung function is declining over time, we know from other studies that they still are getting a benefit from being on the antifibrotic, so long as they're not having a lot of side effects. And so my personal opinion is that I don't agree with that guideline, but that's the guideline, and where we have to prescribe within that.
Okay.
Thanks,
And
Sharon.
and Charlene, there's another question. So a person has said that they were doing their 6-minute walk test and they really want to pass it. So they rested and they passed it, but then they were told they couldn't get their oxygen. And so they had to wait 3 more months. So,
Yeah, so let me talk about that, Sharon. I'm going to get to that. Thank you to
Okay.
that person who put that question in. So I'll just kind of go back to the 6-minute walk test here, and then I'll get to that question. So the standardized walk test, it's a measure of fitness. We do use it in Alberta as a bit of a screening test to determine if somebody needs oxygen or if the oxygen is going to be funded by the Alberta Respiratory Benefits Program. Let me just show you the example of some of the information that we get around the 6-minute walk test, and then we'll talk around that question. And so here's our patient doing her 6-minute walk test. She walked about 500 meters, which is awesome. That's like half a kilometer in 6 minutes, and that is amazing. She was moderately short of breath, 4 out of 10 on her dyspnea scale. The oxygen saturation monitor gives us kind of a ticker tape or a running account of the time. So time 0, and then it gives us data every 30 seconds here at 1 minute, 1 minute, 30 seconds, 2 minutes, etc., all the way to 6 minutes. And then we keep the monitor on for a minute or two after the test is over. We look at the heart rate. So the resting heart rate for this patient was 72 beats per minute. And then it got all the way up to 144 beats per minute because she was really moving, going half a kilometer in 6 minutes. So we would say she has an excellent heart rate response to exercise. Heart rate is supposed to go up when you're exercising, and so this is appropriate. And then we also monitor her oxygen saturation. So she starts at 93%. Which in Alberta, in Calgary, we're at altitude, 93% is normal. If you live at sea level, like at Vancouver, that might be a little bit low to be starting off with. But in Calgary at altitude, that's perfectly acceptable. And when she walked, her oxygen level went down 90%, 88, 86, 84, 80, oh my goodness, 78, 75, 73, 71. Whew. If my oxygen saturation went down to 71%, I would probably pass out. And so this test gives me some really interesting information about this patient when I look at it. She could do 6 minutes, get to 500 meters, oxygen level goes down to 71%, and she's only moderately short of breath. She's not dizzy, lightheaded, anything like that. This tells me that she's probably used to having her oxygen level go down, and so her oxygen level is probably going down lots during the day. The other thing that we have to think about is that on a timed walk test like this, the 6-minute walk test, you have to cover as much ground as you can in 6 minutes. You are going to be walking, most people are walking much faster during the test than they do in day-to-day life. And so it is likely that in her day-to-day activities, this patient probably never goes below 80%. But I wouldn't really know that unless I walk her at her normal pace. And so I would have a conversation with this patient about oxygen, given that her oxygen saturation went so low. When we are discussing the results of the 6-minute walk test or the pulmonary function test or any of our functional tests with patients, it's not if you pass or don't pass the test, right? The test is just giving us a little snapshot of how you're doing at that time. In Alberta, we have these very complicated and convoluted rules about how the province uses the information from our 6-minute walk test, and then they have the patient do the Alberta Aids to Daily Living Respiratory Benefits Program walk test, which is different than how we do it in our standardized way. People do not walk as fast, and so they sometimes do not desaturate as low as they do on our test, which is a timed, go as far as you can, fast as you can walk test. And so sometimes if we see desaturation in our 6-minute walk test in the lab, we do not see that on the provincial walk test, and people don't get funded on the provincial walk test. And so I think that, for this specific person who asked the question, I would go back to your doctor and just discuss that. And your doctor may follow up with something like a hall walk test, which I'll show you in a minute. It's an informal test where we have the patient walk up and down the hallway at their own day-to-day walking pace with the probe on their finger or on their forehead. And we measure what is their oxygen saturation doing with regular day-to-day activity, not the timed walk test, like the 6-minute walk test. And it may be that when you are walking at a more regular pace, that actually the oxygen level doesn't go down and you don't need oxygen. In Alberta, the province has decided that if a patient doesn't meet oxygen funding criteria during the provincial walk test for oxygen, that they have to wait for 3 months before they can challenge it again. I didn't make up that rule. That's what we live with, and then you can work with your doctor to try to find alternatives in the meantime. One of the things that we also do in the lab is called an informal hall walk. So I alluded to this just a minute ago, and these are actually strips from 2013 from a patient that my nurse Kirk was helping me out with in clinic. So this is a patient who's normally on 4 liters of oxygen. And so this ticker tape is a little bit different. The time starts at the bottom, and then the time is reported every 15 seconds. Going up here, I'm looking at the left-hand side here. And when the patient starts the walk test at his own pace, wearing his oxygen at 4 liters a minute, when he's walking at his own pace, his oxygen level falls down to about 77%. And so then what Kirk does is rests the patient, has the patient sit in a chair and rest, catch the breath, turns up the oxygen. In this example, Kirk turned it up to 6 liters a minute. And then we repeated the walk test, and the oxygen saturation, which was much better. This person had pretty severe pulmonary fibrosis. And so this is an informal hall walk test. We're not sending the data to the province. We're having the patient perform some walking to kind of replicate what we would see if he's walking between rooms in his house, or maybe walking to a doctor's office, that kind of thing. And we're trying to figure out how much oxygen does this patient need in order to do the activity without being so short of breath and with a better oxygen saturation. Other exercise tests that you might have heard about is there's one called the cardiopulmonary exercise test, which is when you go onto the exercise bike, you've got a big mask on, you're attached to a spirometer, you've got cardiac leads on, you exercise as hard and as fast as you can, and that's a really sophisticated test. We did research when I was a fellow at the University of Michigan to show that the 6-minute walk test is just as robust as the cardiopulmonary exercise test, and it is a lot more accessible and inexpensive. And so now we use the 6-minute walk test. And then there's also a 3-minute walk test, which some labs in the US are using. And then there's other things like a sit to stand test, which you might do at pulmonary rehab, where you sit in a chair and then they measure how many times you could go from sitting to standing over a period of time at the beginning of your rehab, and then you do your rehab, and at the end they do a sit to stand test as well. It's just a different measure of fitness that we use for patients with different kinds of lung disease. So how to prepare for your time in the lab, either doing spirometry, diffusion capacity, or an exercise test. You want to make sure that before you come that you have just a light meal. Again, not a big meal, because if your belly is filled with a big meal, you're not going to be able to take in a big breath, and you're not going to be comfortable doing the pulmonary function test or doing the 6-minute walk test. If you smoke, you should not smoke. You should take your medications as prescribed. Your doctor or the lab may give you some special instructions about what to do with your inhalers if you are prescribed inhalers, and you should follow their directions for the test. You want to wear comfortable clothing and shoes, especially for the walk test. You want to wear like a runner or a sneaker, something that you could walk in. You want to arrive a few minutes early so that you can get relaxed and calm before you do your test. If English is not your first language, or you're not comfortable in English, you want to bring a translator, although most labs now have access to translators to help when needed. And then in particular, if you wear nail polish, the nail polish prevents the oxygen sensor that we put on your finger from working properly. And so you may have to sacrifice your manicure in order to get a good reading for your oxygen saturation. In the lab, it's really important that you work with the respiratory therapist and follow all of their instructions, because this test and getting good numbers from these tests really depends on how much effort you put in. So really try your best. And just be aware that if you're having a hard day in the lab, the respiratory therapist is going to pick your very, very best numbers, and that's the numbers that the doctor is going to see. And if you're having a hard day in the lab, you can come back in 4 to 6 weeks and try again. Okay, I'm going to move on to chest imaging. Goodness, the time is flying. We're going to talk about CT scans primarily, both the CT scan of the chest and then a HRCT, or high resolution CT scan. I saw this picture on the internet shortly after Sharon asked me to do this talk, and I loved it. And I was so excited to show it to you to help everyone understand the different kinds of imaging modalities and why we do CT scans and x-rays, and then importantly, why we do not do MRIs for the lung. So different imaging modalities show us different things, as you can see with this banana. An x-ray is just the x-ray beams hitting the object, going through the object, and they really give us kind of a flat representation of the object with not a lot of detail in it. X-rays are great because you can get them just about anywhere. They have not very much radiation. They show us big things like the lungs, the heart, the bones, pneumonia, big nodules in the lung, fluid in the lungs, but they do not show us the fine detail of pulmonary fibrosis very well. A CT scan, which is down here in the lower left of the figure, is an X-ray that is given with, instead of one beam of X-ray, it is 64 beams of X-rays coming at you. And then the X-ray machine and the detector circle around you. I have a video to show you in a minute. And you can see that it gives you a lot more detail. So here you can kind of make out, here's the skin of the banana, and inside the banana, you can maybe imagine this is where the seeds are, and then there's a darker bit of the inside of the banana, maybe that like that dark kind of cross bit in the middle of the banana. I don't know what it is, but you can get a lot more detail from a CT scan. A CT scan is really good for looking at the lung tissue. It is the imaging modality of choice for lung. It is a very fancy 3D X-ray. MRI, magnetic resonance imaging, is a very different technology. Instead of using X-rays, it relies on the magnetic properties of water. And you can see here the image looks quite different. You can still see the skin and the flesh of the banana, but you get a lot of different information from an MRI. MRI is great because it doesn't give you any radiation, but it's most expensive, it's hard to do, it's not always available. And then the lung is filled with air, not filled with water. And so it is not a very good modality for the lung, just because the lung is filled with air. So this is a chest X-ray of what pulmonary fibrosis looks like. And so this is like the person is standing in front of you and you're looking right at them. So on the left-hand side of the picture is actually the right-hand side of the body. And then this is the left-hand side of the body. Air is dark. So the lungs are these big dark areas here on either side. The heart is in the middle here. There's a little kind of rounded dark thing here. That's air in the stomach. And then you might be able to appreciate that there's kind of some like spider webby, cobwebby white lines overlying the lungs, and that's the pulmonary fibrosis in this patient. A CT scan gives us much more detailed information. And so again, I'm going to show you the video of the CT scan and how it's done in just a minute. We get what we call many different slices of the CT scan. And here the slices are shown with the patient lying on their back. The lungs are dark, and you can get a sense if you just kind of look around the outside of the lung that there's all these white lines there, and that is the pulmonary fibrosis. What I'm trying to show you with the red lines going across the X-ray is the approximate level of the different slices of the body that we're looking like in the CT scan. I'm showing you here only 4 slices of this patient's CT scan, but in reality, if we got a CT scan of this patient, I would probably get 300 images to go through, and you can kind of play them in a little movie, and it's pretty cool. This is how a CT scan works. This is just a quick video.
A CT scan is an X-ray procedure that creates cross-sectional images with the help of computer processing. CT images are more detailed than conventional X-ray images and can reveal bones as well as soft tissue and organs. A conventional X-ray uses a fixed tube that sends X-rays in only one direction, while a CT scanner uses a motorized X-ray source that shoots narrow beams of X-rays as it rotates around the patient. There are special digital X-ray detectors located directly opposite the X-ray source. As the X-ray passes through the patient, they are picked up by the detectors and transmitted to a computer. Image slices can either be displayed individually in 2-dimensional form or stacked together to generate a 3-dimensional image that can reveal abnormal structures or help the physician plan and monitor treatments.
CT scans are really, really cool. And if I didn't love lung medicine so much, I would be a radiologist. That's how cool they are. So what I wanted to show you from that video is just that visual of how the scanner goes around the body to detect the images. This slide is just some examples of what different kinds of pulmonary fibrosis look like on CT scans. And I show you this slide mostly to drive home the point that many of these scans, so the two here on the left and the two here on the right, these are from 4 different patients. But the x-rays would look very similar for these 4 different patients. But you can see that the x-rays, or the CT scans rather, look quite different from each other. And so the CT scan gives us this exquisite detail of the lung anatomy and the lung architecture. And this is what allows your respirologist or your ILD specialist, together with the chest radiologist, that's the CT scan, the doctor who interprets the CT scan, plus the blood work, plus the history that you provide to be able to determine, is this IPF, is this hypersensitivity pneumonitis, is this something else? And so the CT scan is one of our most important tools to be able to diagnose interstitial lung disease or pulmonary fibrosis. So how often someone should have a CT scan? I think it depends. For sure, you should have one at the time of diagnosis, and ideally you would have a high resolution CT scan of the chest at the time of diagnosis. Those give us the very best images to determine what it is that you have. During long-term follow-up, there aren't any hard and set guidelines about how often we should be doing a CT scan of the chest. So in routine follow-up, the practice varies across the country. So I know that in Vancouver, the ILD clinic out there frequently will do a CT scan once a year. My personal practice is I like to do them every 3 years or so. Is there any data to support my choice? Nope. That's just what I was comfortable with. In the pandemic, we got a little bit behind, and so some of my patients went 5 years between CT scans, and I thought that was a little bit too long. Anytime there's a change on the x-ray, a change on the lung function studies, a change in how the patient is feeling, pneumonia, some other illness, then we typically would repeat the CT scan. And so you don't need to have one every year. You need to have one at the beginning for sure, but then you would get it periodically as routine follow-up and as needed if things change along the course of living with pulmonary fibrosis. The other thing that's new is, what do we do for lung cancer screening? So you may or may not be aware that there's a new Canadian guideline for screening for lung cancer. And that's a low-dose CT scan once a year, up to 3 years in a row for high-risk individuals between the ages of 55 and 74. And so a high-risk individual is somebody who has significant smoking history. We call that 30-pack years. That's either smoking 1 pack a day for 30 years or smoking 2 packs a day for 15 years. And they are either a current smoker, or if they quit, they've quit less than 15 years ago. So that's our high-risk population for lung cancer screening. So some of the, so that I would say, at least in my clinic, I would say probably 25 to 30% of my patients would fall into this high-risk group. But whether or not we should do lung cancer screening in a patient with pulmonary fibrosis, I think, is a question that we need to discuss with our patients carefully. The low-dose CT scan of the chest is different than the high-resolution CT scan. The high-resolution CT scan is a little bit more radiation, and then hundreds and hundreds of images. A low-dose CT scan is lower radiation, fewer images. It's not very good for looking at the pulmonary fibrosis at all, but it is really great for looking at nodules. And so if we decide to do a CT scan for lung cancer screening, I'm not going to be able to look at the CT scan and give you very good information about what's happening with the pulmonary fibrosis, because this scan isn't designed to give me that information. The other thing is that sometimes with pulmonary fibrosis, the fibrosis kind of lines can go on top of each other and look a little bit like nodules where they intersect. And so it takes a lot of training to be able to look at a CT scan screening for lung cancer in somebody with pulmonary fibrosis to determine, is that little spot a nodule, or is it actually just fibrosis crossing over each other? So typically those scans need to be looked at by a dedicated chest radiologist with a lot of expertise. And then the final thing that's a little bit challenging for our patient population is, should we even do this at all? Some patients have such severe pulmonary fibrosis that we would not be able to safely do a biopsy, surgery, radiation, or those kinds of things. And some people have a personal preference that they would not want to have aggressive cancer therapy. And so we really have to understand, what are we going to do with the information before we go ahead and order the test. So if you are a smoker, former smoker, falling in that high-risk category with pulmonary fibrosis, I would have a conversation with your respirologist about the pros and cons of doing lung cancer screening before just going out and getting the test. This test, as I mentioned, is one of the most important tests we have for diagnostic purposes. So it's really important that we get good pictures. And so here are a few tips to get good pictures from your CT scan. So arrive on time to your appointment is key. Usually the radiology department is on the main floor or down in the basement, so it may be hard to find. You want to follow all the instructions. So you want to wear comfortable clothes. You want to leave your jewelry and your watches at home because those metal interferes with the images. You typically don't need to fast or follow a specific diet for the CT scan, but you want to make sure that you have a smaller meal instead of a longer meal, because you will be, or instead of a big meal, because you're going to be lying on the table for a period of time. And then again, if you're not comfortable in English, you want to bring a translator if needed. You're going to lie on the back on the CT scanner table, just like this person is doing in the top picture here. You may get a sense that there's a little kind of headrest that holds the head in place so that you don't move around. This patient has got changed into a hospital gown, and you may or may not need to change into a hospital gown depending on what you're wearing. It's really important when you're on the table that you get yourself comfortable and settled, and then you do not move. If you move, the pictures are blurry and we cannot use the information. So do not move. The scanner is like a big round donut, as you can see here, and the table is going to go in and out of the donut. It's going to go in and out a couple times. Every time you go into the scanner, they're going to ask you to take a big breath and hold your breath. It takes a couple of times for the tech in the CT scanner booth to set up the computer to get the best pictures for you with the minimal amount of radiation. So they do a few little adjustments in the back in order to determine that. So that you go in and out a couple times just to get everything set up. And then they tell you they're going to take the real pictures now. So they want you to take a big breath, fill up your lungs with air, and then you have to hold your breath for 10 to 15 seconds. And then they run you through the scanner. The detector spins around in that big round machine and will give the radiation, collect the information. The high resolution part of the CT, the high resolution CT, is all a computer algorithm for how the computer shows us the information. So you don't need to do an extra scan for the high resolution images, typically. And then sometimes we need special images. And so sometimes they will ask us while you're lying on your back to blow out all your air, to empty your lungs, and then hold your breath with your lungs empty you'll go through the scanner again. That's called an expiratory view, and that's important for us. And then sometimes we may get you to lie down on your belly, so face down. Again, don't move, fill your lungs up with air, and then in and out of the scanner, face down. So those scans are inspiratory, those are the regular scans, expiratory with the lungs empty, and prone, face down. So sometimes we need those 3 images in order to get a really good look at what's going on in the lungs. Okay, so we're a little bit over time. Sharon, can I keep going just for the last section?
Absolutely.
I didn't hear you.
Oh, absolutely.
Okay, thank you.
Fascinating.
Okay, so just the last section is looking at blood work or lab tests. And so these are done at the time of diagnosis to help us determine the diagnosis, to assess your baseline level of health. We do a bunch of blood work before we start you on any therapy. And then we do blood work periodically to monitor for side effects or toxicity of therapy. And again, I just want to emphasize that no single blood test can help us make the diagnosis. We do some special tests for most patients called serology or autoantibody testing, or you may hear it as antibody testing. And we are looking for specific diseases like rheumatoid arthritis, scleroderma, mixed connective tissue disease, etc. These diseases can be linked to pulmonary fibrosis, and they have a different treatment pathway than IPF, for example. So we do special blood work looking for those tests. In some centers, not all centers, but in some centers, we are able to offer some limited genetic testing. And so, for example, in Western Canada, here in Alberta, some parts of Saskatchewan and around the Winnipeg area, there is a family that has a mutation in this particular gene called surfactant protein C, SFPC mutation. And so we are able to test family members for that mutation. In other centers, we may look at telomere shortening or changes in a gene called MUC5B. But the problem with the genetic testing is that it's not readily available for kind of routine clinical use across the country. We are often doing genetic testing as part of clinical research trials. And then the other thing you should be aware of is some of those commercial genetic tests like 23andMe and those other kinds of testing kits are not looking specifically for genes related to pulmonary fibrosis, so I would not spend your money there. Some people are offered special tests for a specific lung disease called hypersensitivity pneumonitis, which is a disease that is in response to different kinds of allergens or antigens. So this woman here has lots of birds, and there's a specific disease called bird fancier's lung, for example. But it's important to know that the blood test by itself does not diagnose hypersensitivity pneumonitis. It just says that you've been exposed to birds at some point in your lifetime. And so we need to take those tests like any of the other tests and integrate them with all the other information that we're gathering when we're working up a patient. This is just a list of the general panel of blood work that we'll do when we first meet a patient in the ILD clinic or before we start treatment to look at general health of the bone marrow, the liver function, kidney function, and immune status. We're really interested in measuring the CBC, or the complete blood count, because we're interested in hemoglobin. That's a measurement of the red blood cells, which carry oxygen throughout the body. So we're interested in that. Many of our drugs can have possible effects on the liver. So we want to make sure that the liver is healthy. The liver also metabolizes many drugs. The kidney metabolizes many drugs. So we need to make sure those two organs are healthy before we start any treatment. And then some of the medications that we use to treat pulmonary fibrosis suppress the immune system. And we want to make sure that you are up to date with all your vaccines and that you do not have latent infection like tuberculosis, HIV, hepatitis, because if you have a infection with one of those organisms and it's lying low in your body, like meaning you're not sick with it, and we give you immunosuppressive therapy, we can unmask that infection. You can get quite sick. So we test for these different bugs so that we can offer treatment before we immune suppress a patient. It looks like a lot of tubes, it really is, but we're only drawing a teaspoon or so of blood into each tubes. It does feel sometimes like you're being sucked by a vampire, but all of the tests are helpful for us. And we're not just ordering them willy-nilly. We're looking at all the numbers to make sure that we're doing the right things for you. While you're on therapy, if you're taking medication for your pulmonary fibrosis or even for other conditions, your doctor is going to order routine blood work to monitor for possible toxicity. So for the antifibrotics, we look at liver function studies every 3 months. And for the immune suppressant medications, we look at your CBC, liver function, kidney function every 3 months or so. Preparing for blood tests is actually pretty easy. If you are able to pre-book your appointments, especially if you have to get blood work every 3 months, I would strongly recommend that you do this if your local lab has an online portal or a way for you to pre-book your appointments. And if you're able to book your appointments a few days before you see your doctor, that's helpful because we get the results generally within 24 hours. Again, you want to arrive early for your test. The lab work that I described in the last couple of slides does not require fasting or any special changes to your diet or medications, but your doctor sometimes may add in an extra test or two that might require a diet change or a medication change. So be sure that you follow all of the instructions. And again, you want to wear comfortable clothes. And in Canada, in the winter in particular, you want to be able to wear something that you can roll up the sleeve past the elbow so that they can get at your elbow to take the blood out. And then the other thing that's quite helpful in Alberta and BC, I think you can do this. Other parts of the province, I hope you can have access to your electronic health records soon. You are generally able, at least in Alberta and BC, to look at the results of your blood work within a few days of the results being posted. And that's particularly helpful because in our lab, at least, we have a lot of patients getting blood work. And our general rule of thumb is if the blood test result is normal, we will not phone you with the normal result. So in my clinic, no news is good news. But if you're curious to know what the results are, you can log into the portal and have a look for yourself. Other doctors may be a little bit different. So I would, if you're going to get a standing requisition for blood work every 3 months from your doctor, I would just ask your doctor or the nurse in the clinic, how do you get results? If they're normal, will you hear? If they're abnormal, how will you hear? It's good to have that conversation before you walk out the door. Okay, Sharon, I'm going to summarize. I'm going to summarize with a little cartoon here, and then we'll take some questions afterwards, if that's okay.
Perfect.
Okay, so in summary, what I'm going to try to show you with this cartoon is how we use all of these tests over time that I've explained to you to care for you from the time of diagnosis moving forward. And so in the beginning, you may have some cough or shortness of breath. You may see your family doctor, and your family doctor may order some kind of basic tests like an X-ray, chest X-ray, PFTs, or blood work. And based on that, your doctor may be worried about pulmonary fibrosis, and then you may be referred to a respirologist. At least I hope you would be referred to a respirologist. And the respirologist would order, right from the beginning, CT scan with high resolution images, or HRCT. You would do PFTs again, because generally what we do in our lab, we like to get the same testing on the same kinds of machines moving forward, because there's a little bit of variability from machine to machine. So we would like to get you on our equipment and do the lung function test. We'll do a 6-minute walk test, and then we'll do that big panel of blood work, typically, if you haven't had one done by your family doctor, to see your kidney health, lung health, or CBC, etc. The respirologist will see you in follow-up, maybe at 6 months or 3 months. And at that time, generally, we would do the breathing test and the walk test again. If you just had a CT scan 6 months ago, there's no real need for us to repeat imaging of the chest, unless things are really changing rapidly. But for most patients, we don't need to repeat an X-ray or a CT scan. 6 months is kind of a good amount of time for us to see if there's any changing in the breathing test or the walking test. So say you do that and everything's fairly stable, you're feeling pretty good, you go back in 6 months after that, you get PFT, 6-minute walk test, you may get a repeat X-ray or a CT scan at that point. And say at that point you finally decide, after discussing with your doctor and your family members, that you want to start a medication for pulmonary fibrosis. Your respirologist will do baseline blood work again, because it's been about a year since you had the blood work that was done at the very first visit. So we need to get updated blood work before we start you on these medications. Once we start you on the medications, you get a follow-up generally within about 3 months. You might get a call from the nurse a little bit sooner to see how you're tolerating all the pills. But at 3 months, we'll do our blood work to make sure that your kidneys and your liver are happy with the medications. At that point, you may or may not get a breathing test or a walk test. And then after that, if everything is doing well, you would get blood work again at 3 months to monitor kidneys and liver. And then you would go back to see your respirologist at 6 months with breathing test, walking test, and blood work again, and so on and so forth.
Charlene, someone was asking, they were told that they could eat breakfast as usual before the blood test, and they go every 2 months.
So I can't comment specifically on why that person would need to go every 2 months. But eating breakfast as usual sounds very reasonable for the kinds of tests that we normally do.
Okay, thank you.
Sounds reasonable. Yeah. One caveat to this little schematic is that if things are changing, so if the breathing test has fallen, if you get pneumonia, if you fall and injure yourself and break some ribs, we would kind of shorten up that follow-up to monitor you a little bit more closely. So you might not go every 6 months, you might go every 3 months or 4 months, etc. So finally, all of these tests are really important for us to diagnose and manage your pulmonary fibrosis. They help us determine the diagnosis, all of these bits of information working together in conjunction with each other. And they help us develop a plan to manage your pulmonary fibrosis, live your best life with this disease. Why don't I pause here for questions? Maybe Shane, you could put the slides down. I'll stop sharing. There we go. We can have some questions.
Yeah. So, Charlene, someone wanted to know, when you're doing all these tests, I mean, if they remain stable, they're very happy. But if they don't and they show worsening, what would your doctor do? Like, what other tests could you do, or what would they recommend?
Yeah, that's a good question. So the question is, what do we do when things are worsening? So the first thing that we think about when things are worsening is, the possible reasons why things are worsening is something going on, like is the patient sick with an infection? Is there another medical condition, usually to do with the heart, or broken ribs or something like that? Are they having a bad day in the lab, or is the disease really progressing? So if the numbers on the pulmonary function test have fallen, we would have a discussion with the patient about maybe repeating them in 4 to 6 weeks. If the patient comes into the clinic and says, oh, I feel terrible, I'm coughing, I'm bringing up phlegm, I have a fever, then it's pretty obvious that there's a pneumonia. I would treat the pneumonia or the infection, and then we would repeat the scan. But sometimes we do all those things and the lung function has fallen because the disease is progressing. And unfortunately, with many, many forms of pulmonary fibrosis, there's more than 200 different kinds of pulmonary fibrosis, and many of them are slowly going to get worse over time. Many of them are going to get worse over time, even if you are taking medication to slow down the progression of the disease. The key with the medications is that they slow down the progression. They don't stop the progression altogether. So, it's kind of hard to wrap your head around it, but the disease is going to progress over time. And so when the pulmonary function test is getting worse, or if the 6-minute walk test is getting worse, or if you're just feeling worse and there's no other cause like an infection or a bad day or something like that, that might be a time to talk to your doctor about medication if you're not on medication, like an antifibrotic if you're not on an antifibrotic. Or you might talk to your doctor about pulmonary rehab, or you might talk to your doctor about oxygen, especially if your oxygen levels are low during a walk test. Or you might have a more general conversation with your doctor about, like, what is really going on here? How bad are my lungs? What is my prognosis? How many years do I have left? How can I manage this cough or shortness of breath? Maybe there's some other techniques to try, breathing exercises, other medications to help with symptoms. Do I need some things in the home to help with mobility, like stool for the bathtub, stair lift, wheelchair, walker, those kinds of things? So, even though it's difficult to see that the lung function is changing over time, it provides you and your doctor with an opportunity to talk about where are you at right now with your lung disease, and to try to figure out what is the best thing that we can do right now to help you feel as best as you can, whether it's medication, oxygen, rehab, wheelchair, what have you. How can we help you manage your disease where you are at right now?
Great. So that brings up to the next question. Someone wanted to know, is there any way to quantify at what level before you start taking oxygen would be beneficial?
Oh, that is such a great question, and we don't have any research that has specifically answered that question. So the American data, the American guidelines suggest that if your oxygen level falls below 88%, you should be on oxygen. In Canada, our oxygen paper is, I think it's still in press, right, Sharon? It's not published yet.
No,
We have a, it is?
It just got published on Friday.
On Friday. Okay, well, that's why I haven't seen it yet. Published on Friday. Our paper describes how in different provinces across Canada, the cut points for where you get oxygen funding are a little bit different across the country. And so I would like to be able to say that if your oxygen level falls to this number, you get oxygen, but I can't, as much as I think that everyone should have better access to oxygen. It's a conversation I would bring up with your respirologist to find out what the rules are in your particular area. Your respirologist would be the best person to answer that question for you.
Well, Charlene, it's been almost a decade since we've had the 2 drugs that you had referred to in your conversation. Someone wanted to know, when will be the next drug coming up to Canada? Specifically, they wanted to know about Fibroneer.
Yeah, thank you for the question. So the details of the Fibroneer data are going to be presented at the American Thoracic Society meeting at the end of May. I think it's in San Francisco this year. So the meeting usually corresponds with the May long weekend. And then what happens in drug development and approval is then the drug is reviewed by the FDA in the US. And I'm not really sure how that process is going to go, given that there are significant changes being made to various American government departments right now. So I don't know what that FDA review is going to look like and how long it's going to take. typically after the FDA approves the drug or after the European Union approves the drug, Health Canada will take that work, because it's expensive and it takes a long time, and adopt that work and approve in Canada. So typically the Canadian approval happens 8 to 12 months after an American approval. When pirfenidone came on the market back in 2013 or so, we actually had approval following European Union approval. Canada approved based on the European data, and the Americans had to do another set of studies before the FDA approved it. So I'm not sure when Fibroneer is going to come to Canada, but you can expect that after a positive landmark trial is released, and we'll have to see if the results of the Fibroneer study are spectacular in May. Fingers crossed. We all hope they're spectacular. I would say probably 12 to 18 months after that, we could expect to start getting news about when it will be commercially available in Canada. For patients who are followed by a respirologist, or patients who are part of the clinical trial, there are patients that are currently on drug here in Canada as part of the clinical trial. But we are otherwise, if you're not part of the clinical trial, we're not able to offer it to other patients until it is formally approved by Health Canada. So if we get a good result in May of this year, I think the earliest we would be able to start prescribing would be the summer of 2026, most likely the fall of 2026. I hope that answers your question.
Yeah. Well, thank you. Everyone wanted to let you know that your session was so informative, and they really appreciate the time and the consideration you put into the research, and really letting them understand why they have to do all these tests, because many people are just frustrated. They don't really understand, but now they do understand, and they appreciate the effort it takes for them to go through it.
Well, thank you very much. It was a pleasure to give the talk. And this is great. You know, this talk came about because people ask Sharon questions, and I know Sharon collects all your questions. And when she gets a cluster of questions that follow a theme, then she approaches one of us ILD doctors to give a talk. So send the questions in. We appreciate it. And my colleagues and I are always happy to present on interesting topics. Thank you very much.
And thank you for the generosity of your time, because I know you could do so many other things today, but thank you for taking the time out and spending it with us and showing that you care about, us and our community. Thank you.
Thank you.